ocular surface squamous neoplasia. So let me get started. So as you know, the ocular surface squamous neoplasia is the ocular surface tumor. And then it is reported that the prevalence of the OSSN is estimated between the 0.2 cases per million per year and 35 cases per million per year. And then also it is known that the HPV infection is associated with the ocular surface squamous neoplasia. And then HPV 16 and 18 are associated with the malignant neoplastic regions, while the HPV 6, 8, and 11 are associated with the benign conjunctival epithelial regions. So this ocular surface squamous neoplasia is categorized to the three types of the tumor according to the stage of the tumor. So if the dysplastic epithelial cells are seen partially in the epithelium, it will be dysplasia. While if the dysplastic epithelial cells are seen in the whole epithelium, but the basement membrane remains intact, that it will be CIN. And then also the dysplastic epithelial cells penetrated the corneal basement membrane, it will be a squamous cell carcinoma. So I like to show the fluorescent technique which helps to detect the tumor margin. So here, if it is the case in the picture on the left, so you can see the tumor margin easily. But if it's case in the picture on the right, so sometimes it will be very difficult to detect the tumor margin. But in that case, fluorescent technique will help to detect the tumor margin because you can see they're easy to see the tumor margin by staining the fluorescent. And then also we usually use the listamine green instead of the fluorescence technique. So because it's more easy to find out how big the tumor is. So for the surgical treatments, we usually, of course, remove the tumor excision and then also the mitomycin treatment at the time of the surgery. But if it's a very large tumor area, tumor region, so we also add the amniotic membrane transplantation or sometimes keratoepithelioplasty for the ocular reconstruction. And then once the ocular surface became stable, so we also gave the 5-FU treatment for a week, adjuvant therapy. But sometimes we see the recurrence of the tumor. So therefore, we analyze the retrospectively to determine whether or not the combination of surgical excision and postoperative topical 5-FU treatment can successfully prevent the recurrence of OSSN. So we first collected the medical records from 86 cases, which are pathologically diagnosed as OSSN between the 1996 and the 2019 at KPUM. So we excluded the 16 cases for some reasons, as shown here, and we finally analyzed the 70 cases retrospectively, and then mean for a period is about 3.2 years, ranging from the 2 months to almost 14 years. Here are the subject of this research. The 42 male and the 28 female are included, and the mean age is about almost 72 years old, ranging from the 32 to 91st years old. And then half of the subjects is squamous cell carcinoma, and then 40% of cases is CIN. The 70% of cases is dysplasia. And then also we divided the whole groups into the four groups according to the tumor regions. This is the small tumor and then mild tumor, and then also the bit large area invasion, the paravelar conjunctiva, and this is a very severe case which are embedded into the valvular and the paravelar conjunctiva. And then if the tumor is very small, we didn't do anything, just remove the tumor region. But if it's large and then still it is observed in the conjunctiva, we did the amniotic membrane transplantation alone. But if the tumor is embedded into the cornea, so we actually need to perform the limbal transplantation or keratoplasty. And then sometimes we need to perform the COMET, cultivated oral mucosal epithelial transplantation, and also the autologous conjunctival epithelial transplantation. So in terms of the recurrence of the tumor, so we saw that almost 30% of cases did show the recurrence, and then more malignant regions tend to show the more recurrence. And then the recurrence happened around almost 1 year after the surgery. So we wanted to know what is the factor that influences the tumor recurrence. And then we firstly examined the patient background to see which factor, which variable is the risk that influences the tumor recurrence. We check the age, patient age, and the sex, and the pathological diagnosis, and the lesion location, and the size, and the HPV-16 positive or not. And we found that age is one of the risk factors to develop the tumor recurrence. But I don't think it is a risk factor because you can see the hazard ratio, which is very low, almost 1.0. So if it's significant, I don't think it's clinically a relevant risk factor. However, you can see here the valvular and the paravelar conjunctiva, and also the bigger size seems to be a high risk factor to develop the tumor recurrence. And then we also check the surgical treatment, like operation, and then also MMC treatment at the time of surgery, and also the post-operative 5-FU treatment or interferon treatment. And then what was found here is that 5-FU treatment was significantly the factor that reduced the tumor recurrence. And then also this survival rate did show that the 5-FU treatment actually improved the survival rate, which is 90% of the success. And then, if you didn't use the 5-FU treatment, the survival rate will go down to the almost 40% of success. And then also we need to think about the patient's visual acuity improvement, because when we see the patient like this, we actually need to perform the ocular reconstruction, like by using not only the amniotic membrane transplantation, but also like give the cell source, like the limbal epithelial transplantation, or in this case, we performed the COMET surgery right after the tumor excision and MMC treatment. And then also in this research, in this analysis, most of cases did show the improvement of the visual acuity. At least their visual acuity remained and they maintained in most of cases. So here in summary, so we think that the tumor size and then postoperative 5-FU eye drops were significantly associated with the recurrence of ocular surface, ocular squamous neoplasia. And then also the postoperative visual acuity maintained or improved in 25 of the 29 patients after tumor excision combined with the ocular reconstruction. And then recurrence rate was significantly lower in the group with the 5-FU eye drops compared to the groups without 5-FU eye drops. So thank you for your kind attention.
Thank you very much, Dr. Kitazawa, for the very interesting presentation and very interesting study. I think there will be a lot of questions and discussions, but I think we can move the discussion into the later sessions after the presentation of our two residents. So we move on to the next sessions, a case presentation from Universitas Indonesia by Dr. Nabila Al-Jufri, who will present a case of ocular surface squamous neoplasia in a child with xeroderma pigmentosum. Please, Dr. Nabila, the time is yours.
Thank you very much, Dr. Jessica. Good afternoon, professors and doctors. My name is Nabila Al-Jufri, and I will present a case of ocular surface squamous neoplasia in a child with xeroderma pigmentosum. So this is a case of 12-year-old girl. The chimp complained of worsening growth of whitish lesion and blurry vision of the right eye since 4 years before admission. Patchy pigmented lesion all over her body were noticed since 8 months old, but never got medical attention. For the ophthalmological status, so the visual acuity was hand movement with the palpebral of multiple and dry, scaly, mottled, hyperpigmented and hypopigmented macules, not only on the palpebra but all over the body. Foamy tears of upper and lower eyelid with lash line. At the conjunctival bulbi, we can see leukoplakia at 9 o'clock with hyperpigmentation at the temporal inferior and nasal side with slight conjunctival injection. Whitish lesion at the central to paracentral area with prominent neovascularization continued to the conjunctiva here at 3 o'clock. For the left eye, the visual acuity was 6/6 with same palpebral condition, hyperpigmentation at the conjunctival bulbi with hyperpigmentation area at this nasal side with clear cornea condition. Anterior segment OCT showed thickened hyperreflective epithelium and distinct border of epithelium and Bowman membrane. The ultrasonography of the right eye showed clear posterior segment with intact optic nerve. And we assessed this patient with ocular surface squamous cell neoplasia of the right eye, suggestive invasive, and xeroderma pigmentosum, and planned for surgery. So during the surgery, first we mark 3 to 4 millimeter for the white excision and carefully excise the tumor with alcohol keratectomy and doing double freeze-thaw technique. And then the specimen is put onto the paper and we give mark at the several sites for histopathological examination. The cornea was given dry amnion membrane and bandage contact lens. The histopathological result showed squamous cell carcinoma. 1 month post-operative, we can see improvement of the visual acuity from hand movement to 6/30 and corrected to 6/18 with the same palpebral condition, conjunctival injection, and amnion membrane have not been dissolved. And she is still using bandage contact lens. 3 months post-operative, we can see the same visual acuity with same palpebral and involve a resolution of conjunctival injection, clear cornea with cicatrix at the central and neovascularization at the inferior part. We have to note here the relatively slow healing process in this patient because it is hampered by the xeroderma pigmentosum. From the pediatric department, they suspected a mass at the neck area, suspected metastasis of squamous cell carcinoma, and she was given systemic chemotherapy for 10 times, given bleomycin and methotrexate intravenously. She was also consulted to dermatologists. And after finishing the chemotherapy, FNAB was performed and no mass or fluid cysts, only fluid cysts showed. And this is the timeline of the patient. So we can see at the initial visit, the visual acuity was 1/300 or half movement. And this is 3 months post-operatively. And xeroderma pigmentosum. The definition, it is a rare condition which have defective UV radiation-induced damage to the DNA that is characterized by photosensitivity with easy skin burning following minimal sun exposure. It showed early fleckling of lentiginous pigmentation along the skin, and it gives the risk factor of developing skin cancer at the early age. So what happened in xeroderma pigmentosum? Usually, in normal condition, we have this nucleotide excision repair that will cut the DNA base that is having mutation and replace. However, because of the DNA damage in xeroderma pigmentosum, they have not good repair for the nucleotide excision gene. So when there's exposure from the UV light and having the reactive oxygen species, it will induce cell death, mutagen, and genomic defect. This will lead to photosensitivity and cancer, having the xeroderma pigmentosum. What is the connection between ocular surface squamous carcinoma and XP? OSSN, as has been mentioned before, it is a wide spectrum of a disease involving the abnormal growth dysplastic squamous epithelial cells on the surface of the eye. It is predominantly occur at adulthood, but in patient with XP, it tends to occur at a younger age. What happened? It has the unable to repair the DNA damage by the UV ray, leading to stomatic mutation and cancer cell, leading to the increased susceptibility to OSSN and having younger age presentation. And what is the treatment? Excision biopsy with triple freeze-thaw cryotherapy with optional chemotherapy, caution using the topical MMC or 5-FU. And we also give systemic chemotherapy when needed. So indication with systemic chemotherapy in this patient was the suspected of metastasis of squamous cell carcinoma to the neck. The bleomycin is having the inhibition at the double check repair at the G2 phase. And for the methotrexate, it is a metabolite that helps the DNA synthesis. For the matomycin C itself, it is a non-cell dependent alkylating agent that induces DNA damage in aerobic and anaerobic environment. It can be used as a neoadjuvant, adjuvant, or the primary treatment for SSN. For the concentration, it is 0.02% to 0.4% for times per day for 1 week, and then off the cycle for 1 week for 3 cycles. Because it may have effect on the ocular surface, this patient was not given the mitomycin C, noting the slow healing process in this patient. Points to highlight: another paper by Gupta et al. Showed that present having 7 patients of XP with all presented at a younger age, showed that 93% the OSSN occurring at the limbus, with 43% showing invasive squamous cell carcinoma and recurrence in 64% of the patient. So in this patient, the risk factor of OSSN is the xeroderma pigmentosum itself. And the prognosis, approximately 60% of patients with XP will die before the age of 20 years, with the median age of death is 32 years, as having the metastatic skin cancer as the leading cause of death, followed by neurodegeneration and internal cancer. So what we should inform the patient? For patient care, we should ask the patient to avoid cigarette smoke, wear non-porous clothing, using rigorous SPF, remain indoors, having sunblock, and having a UV blocking system, having the regular eye check, and seek psychiatrists for psychosocial issues that need to be addressed. So in conclusion, OSSN is rare in pediatric case, but may be seen in XP patients. In this patient, the risk factor of developing OSSN, as well as risk of hampering the treatment, is the condition of xeroderma pigmentosum itself. The topical pharmacotherapy, chemotherapy is held in this patient, as this patient have slow healing process. And the challenges for the surgery in our patient is because the tumor mass predominantly occur at the corneal surface instead of the limbus or the conjunctiva. So the excision need to be performed with extra caution. Systemic condition challenges is the suspected metastasis. So this patient need to have the regular checkup for the dermatologist, ophthalmologist, and also pediatrics. Precaution for the cutaneous malignancy, including basal cell carcinoma, squamous cell carcinoma, and malignant melanoma in sun-exposed area, it is the leading cause of mortality in this kind of patients. Thank you very much.
Thank you, Dr. Nabila, for a very interesting presentations. So before we move to the next sessions, I want to remind to all the residents or doctors who want to ask for the first presentation, the lecture from Dr. Kitazawa, or for the case by Dr. Nabila, please write the question on the chat box. So we move to the next presentation, Dr. Yu Fujimoto, case moto.
Can you hear my voice? Can you hear my voice?
Yes, we can hear your voice clearly.
Thank you. Okay, good afternoon. こんばんは. Nice to meet you. My name is Yu Fujimoto, PGY3, and I belong to the Department of Ophthalmology, Kyoto Prefectural University of Medicine. I'm happy to have this opportunity to talk about persistent red beyond the battle with eye drops to everyone. Okay, let's get started. Supervisor is Dr. Fukuoka. Thank you. The first case is a 57-year-old man. He was aware of a growing tumor in his right eye and visited a nearby doctor. He was suspected of having a conjunctival tumor, so referred to our hospital for detailed examination and treatment. These are the findings at the time of his first visit to our hospital. A white raised lesion is found below the right eye. Cashier images. The extent of progress was maybe unknown. Maybe this line there is tumor or sclera. HPV TS PCR was negative. SCC was suspected, and it was decided to perform dissection and MyCC and AMD. And this is I show surgery photos. Oh, sorry. Please wait a minute. Okay, sorry. And the lesion was dyed with lissamine green and resected with a margin of 2 millimeters after excision, mitomycin C for 4 minutes. applied and watched with 300 millions of physiological signs, and the amniotic membrane was passed and operation was completed. Pathological examination is SCC. Sorry. This is POD1 images. After the operation, levofloxacin and betamethasone eye drop was started, each 4 times per day. Until the second day after the operation, he take 1 milligram betamethasone. On third and fourth day after the operation, he take a 10 milligram prednisone. 5 after surgeries images. No recurrences without using 5-FU. So we ended a follow-up. Case number 2 is 51 years old female. She visited nearby doctor to complain hyperemia with right eye. She was diagnosed with bacterial conjunctivitis and was prescribed gachifloxacin and chlorometron. However, she was don't go hospital regularly. After 6 months, her condition was getting worse, so he was referred to our hospital. These are findings at the time of her first visit to our hospital. Hyperemia and epithelial defect were observed on the inner side of the right eye. Moxifloxacin and betamethasone eye drop each 4 times per day were studied. However, she didn't improve. We decided to conduct surgery. I show surgery photos. In the same as first cases, lesion was with Lissamin green and resected with a margin of 2 millimeters. After excision, mitomycin C was applied for 4 minutes. These images and washed with 300 milliliters of physical saline. After that, the amniotic membrane was fasted, and the operation was completed. This is POD1 images. We start levofloxacin and betamethasone eye drop each 4 times per day. The biopsy result was SCC with positive margins. Because no obvious lesions were observed on the surface, it was not to perform additional resection. PET CT is no metastasis. 1 month after surgery images, no epithelial defects were observed. On this day, 1% 5-FU eye drops were studied. However, it was discontinued after 1 week due to subconjunctival hemorrhages. This is a photo after 4 months. There was no recurrence. 1 year after surgery, there was no recurrences. So we end follow-up on this date. By the way, which pictures is SCC? Let's thinking. Number A, number B, number C, number D. Okay, the answer is all cases is SCC. Sorry. Okay, take home message, last pages. In our hospital, we get good result because of using Lissamin green during surgery to identify area of tumor and getting safety margin, and using mitomycin C and AMT. SCC must be suspected if persistent hyperemia is observed with only eye drops. What I would like to say is there will be SCC beyond the battle with eye drops. For hearing my voice. Thank you.
Thank you, Dr. Fujimoto. It's a very good take-home message to expect any persistent hyperemia as a tumor, right? Okay, so we move on to the next sessions, the commentary from panelists from Universitas Indonesia. Please, Dr. Neni or Dr. Nina.
Thank you, Dr. Jessica. Good afternoon and konbanwa to our friends, professors and doctors from Kyoto Prefectural University. It's my pleasure to, I'm really glad that we can have this meeting, and the lecture from Dr. Kitazawa really to the session that we're having right now. So maybe some cases, some comments on the case. First, maybe from Dr. Nabila Jufri. Perhaps it's a different highlight of OSSN or SCC, kind of different of what we used to see. The one that is presented by Fujimoto maybe was kind of the regular cases of OSSN that we usually see. Old patients, and then having with chronic redness and leukoplakic mass in the eye. But in Dr. Nabila's cases, the patient was only 15 years old, yeah, Dr. Nabila, and it's quite rare to have children with OSSN, but we have to note in every patient that has immunocompromised status, and patient that may be undergoing an immunocompromised therapy, systemic therapy, or in this case, patient with some syndrome like xeroderma pigmentosum. So actually the supervisor was me. He was my patient, and I would like to ask some comments from Professor Tezono and also from Dr. Fukuoka on using the systemic chemotherapy in this kind of patient, because we decided that we cannot give additional adjuvant therapy regarding the poor ocular surface of this patient with the xeroderma pigmentosum, and thus we collaborated with the pediatrics, and we agreed on giving her systemic chemotherapy, and fortunately the result turns out good. And some commentary for Dr. Fujimoto's cases. The last slide was really intriguing. It's not as obvious as we usually see with redness and feeder vessels for SCC cases, and it's those two cases really an eye opener for us that we should not really just let our patients with chronic redness go and just give them the usual therapy, that we need to pay more attention that it may be malignancy cases. Maybe that's from me, Dr. Jessica. Thank you.
Thank you, Dr. Nina. Maybe Dr. Neni, can you also give some comment maybe about the two cases before?
Yes. Thank you, Dr. Echi. Konbanwa, everyone. I'm sorry, I'm in the car because it's my schedule to go to other hospital. Very interesting a bit to study from Dr. Koji Sensei, I think, yeah. You did the study, a retrospective study for 24 years. I was amazed because you still have the record, the medical records, and for 24 years, and you still have it, because unfortunately this kind of study with a long-term long-term until 24 years, it's probably not feasible at our hospital because in my experience, we are very hard to find or hard to get the full medical records only in 10 years. It's so very hard. It's probably we usually do the retrospective study only 5 years back. Yeah, so I was amazed with your study. You can pull out the data for 24 years. I think it's a very, very valuable study. Yeah? And then the result was excellent. And my experience in our hospital probably like 20 years ago or 15. Yeah, before I was a staff here, we still don't use the cryotherapy for the excision, yeah. But now the cryotherapy itself is a must. It's mandatory after we did the excision, so it's a gold standard for us. And we, unfortunately, we still cannot use the 5FU like in hospital because it's still not yet available here. But we are trying to ask the board of the hospital to facilitate to apa ya, to get the regimen of the 5FU, because nowadays we use the regimen that was available, that is available at our hospital is only mitomycin C, only that, and we still, and as you all know, the mitomycin C has more side effects on the ocular surface compared to the 5FU topical. So that's the, I think that's the different management here in our hospital, in Cipto Mangunkusumo Hospital, compared to Kyoto Prefectural Hospital. And then about the presentation from Dr. siapa tadi, Ci?
Dr. Fujimoto.
Yeah, Fujimoto Sensei. I think it's a very very interesting cases, because all of the case came to your hospital. I think it's in early stage, yeah, because most of our patients came to our hospital came with more larger and advanced lesion, advanced size of the tumor. So sometimes we face difficulty to get the clear margin, because usually our patient come from a low to moderate status of economic and apa tuh pendidikan tuh? Apa sih? Oh, education.
Education.
Yeah. they most of them come from low to moderate status of economic and education, and they delay come to the hospital. So probably a little bit different, a kind of patients that we see every day in our hospital than at your hospital. I think it's all, Dr. Echi.
Thank you, Dr. Neni. There's a question on the floor in the chat box from Dr. Tono. Dr. Tono like to ask about the OSSN in pediatrics. How long and how often should we evaluate the patient after treatment? And what are the routine examinations that should be conducted?
Okay, maybe I have some commentary on that, but maybe Dr. Fukuoka, Prof. Sotozono have also some comments on the question. But most ideally, maybe as presented in Dr. Fujimoto's slide, we need to do PET-CT to be able to work up and screen whether there's tumor outside the eye systemically. But since we don't have that, then we need to do a regular check-up or work-up, maybe every 6 months. But we need to see the patient after all the remission. We need to see the patient firstly every 3 months, and then 2 times, and then at least every 6 months. But since this patient is highly have a high risk factor, then I think collaboration and multidiscipline examination by the pediatric and the dermatologist is also very important to know whether there's another malignant lesion the skin, not only the eyes. Maybe, yeah, that.
Thank you, Dr. Nini. Maybe is there any comment from Prof. Sotozono or Dr. Kitazawa or Dr. Fukuoka, please?
Thank you very much for the presentation of interesting case. So visit after treatment is depend on the case. When the tumor is small, complete excision is possible. In such case, so every 2 or 3 months post-surgery. But sometimes so OSSN cover the cornea, so totally cornea epithelium is replaced by OSSN. In such case, we do keratoepithelioplasty or limbal epithelial transplantation to reconstruct ocular surface. In such case, we use soft contact lens to cover the cornea. In that case, every month we check and you change the contact lens. So today's case presented by Fujimoto is a small tumor, but sometimes we experience the very large case. In such case, so keratoepithelioplasty and amniotic membrane transplantation is necessary. So advanced case every month I follow. And sometimes patient this ocular surface squamous neoplasia is rare disease. So therefore, patient come to KPOM. So far, the patient lives far from here and old. In such case, every 3 or 4 months. So the interval is depend on the case. And we sometimes select radiation. So the Dr. Kitazawa's presentation is a OSSN, surgically treated OSS. But very, very advanced case, we don't, we use radiation. 福岡先生どうぞ。
Good evening, everyone. こんばんは。My name is Hideki Fukuoka from KPM side. Thank you very much for your presentation. These are our comment and question. In our presentation, some cases are difficult to diagnose with almost only red eye. As the title suggests, the persistent red beyond the battle with eye drops. I introduced again this to emphasize the need for special attention in cases where eye drops are ineffective. As you can see, risk factor for OSSN include ultraviolet and chemical exposure and contact lens wear and HPV. I believe there are regional difference in places like Indonesia and Japan. So clinically, I feel that most OSSN are centered found in the nasal contact fiber, a common site for pterygium. How about in Indonesia?
Yeah, it's the same here in Indonesia. Most sites are there, but we rarely see the one that Nabila presented. I think until now we have 2 cases that mostly it is on the cornea rather than the conjunctiva or the limbal conjunctiva. But the same, most are like the pterygium location.
Thank you very much.
Well, so
Okay. I have a question. Dr. Eci ke profesor yang perempuan itu siapa namanya?
Satozono.
Yeah, to Dr. You said that in a large case of tumor, you also do the limbal transplant. How do you do it? Is it on one stage after excision and then you straight do the limbal transplantation operation, or 2 stage? First the excision first, and then you wait for a while and then do the limbal transplantation. And also for the large tumor, you said sometimes you do the radiation. Is it stereotactic radiation, or what kind of radiation? Is it stereotactic or IMRT? Thank you.
Limbal transplantation, we do limbal transplantation just after tumor excision at the same time. At
one stage.
At one time. First, I remove tumor with safety margin and mitomycin C sponge, so 4 minutes.
4 minutes, yeah.
And washing and therapy, and if necessary, amniotic membrane transplantation at the same time.
About the limbal transplantation, you get from FEI?
No, from iBank. So
from
iBank, donor.
Donor, iBank. Okay. And then the doctor?
Radiation, we consult to the radiation specialist. So.
But then the case must be without without vision, or is still have vision? The patient with the radiation, the patient still have vision. Did you also transfer to the radiotherapy
6
treatment?
weeks radiation. So after 60 grade, 6 weeks, 6 weeks after radiation completely disappear. And I have no experience of the residual tumor case.
Oh, but only radiation, or after radiation and then you excise the tumor?
Depend on
No?
the case. So presented
okay.
very severe case.
Yeah, yeah.
We
Okay.
rejected tumor and comment, data comment radiation. Special case.
Okay. Yeah, special case, yeah. Okay, thank you,
Well,
Doctor.
can I add something about the adjuvant therapy?
Of course, please, Dr.
Yeah,
Kitazawa.
so because in our retrospective analysis, we did show that adjuvant therapy, like 5FU treatments, can successfully reduce the recurrence rate. So because we think that even we remove the tumor with a safety margin, we didn't know if there are residual tumor cells, because we couldn't find out where are the tumor cells with our own eyes. Even we use the microscope, we couldn't know where it is. That's why we think that it is very important to add the topical post-operative 5FU treatment. So I think mitomycin treatment also will be possible to reduce tumor recurrence. But in our hospital, we use topical 5FU treatment. And then for 1 week, once ocular size became stable. And then I think we used to use for 3 weeks, but we have found one case that showed the corneal defect that's after the treatments. So that's why we shifted to the 1 cycle for 1 week, 4 times daily treatments. And then now, so as I showed here today, so the 5FU treatments successfully reduce the recurrence rate compared to the without treatment. So therefore, I strongly recommend that if you see the patient with OSSN, even if you feel that you can remove the tumor with safety margin, the topical post-operative adjuvant therapy would be good to reduce the recurrence.
Yes, I agree, Doctor.
Okay. Maybe a quick question. Do you have the 5-fluorouracil 5FU as an eye drop medication already, or you have to build up the medication, customize it from the IV drugs?
Yes. We order the pharmacist in our hospital, and then they give us the topical,
so it's not okay. So it is self-manufactured, not really ready.
Yeah.
So usually, how many cycles do you perform?
One cycle for a week.
Only one cycle? Only?
Yes.
1 week? Only 1 week?
Yeah.
Oh, so is there any side effects?
No side effect for 1 week. But 3 weeks,
okay.
we used to do the 3 weeks.
Oh, 3 weeks, but
at the time, so we
continuously.
So for 3 weeks.
Or you only 1 week on and 1 week off, and on and off for 3 cycles, or continuously 3 weeks?
And 3 or 4 weeks. Wait, interval.
Continuously, Doctor?
when the pathological findings is very severe, sometimes two weeks, but usually
2
1
weeks.
week.
Okay. So you don't have, you didn't, you never used the mitomycin C, 0.04%?
In Japan, so almost 40 or 50 years ago, mitomycin C was used for pterygium, and a lot of complication developed. So therefore,
Yes.
doctor do not prefer.
Never use it again. So you use it 40 years ago?
Oh, I will check.
So, but you still use it intraoperatively,
But
yeah?
you still use it, yeah?
Yes,
Intraoperatively,
we
yeah?
did it. Yeah, we used it at the time of surgery. Yeah.
Okay.
One question from chat, and so Lissamin green. So Lissamin green or fluorescent sometimes very useful to detect the tumor margin, but not in all cases. So therefore, when we suspect OSSN, we use fluorescent and Lissamin. And very good choice.
I think listening green is particularly useful in OR, so surgery.
To margin.
Yes.
So how many millimeters from the tumor margin that you usually excise?
2 millimeter.
2 millimeters,
Yes.
yeah. Okay.
Maybe I want to ask also, Professor, about you do limbal stem cell transplantation if there is a limbal involvement. So how many clock hours you decide to do comment, or if it's like less than 2 clock hours, do you do that transplantation, or how many, the extent of the limbal involvement you decide to do limbal stem cell transplantation?
So more than half. Okay. The tumor is なんだろうな。うまく言えないな。半周以上。なんて言ったらいいの more than
Well, 3/4 that so half of the tumor is half of the like cornea is invasion. So we decided to choose the stem cell therapy.
More than 2 quadrant, yeah.
Yes.
So more than 50, more than
Yeah.
180
Yes.
180 degree, more than 180 degree, yeah. Same, yeah. Usually the patient that experience the limbal stem cell deficiency is the cases that very advanced that involve the more than 3 quadrants. Yes. So you should do the limbal transplantation after excise the tumor. Yeah, I agree.
Yes. Can I ask one more question, maybe to our friends from Kyoto? Do you have any experience with chemotherapy, Prof. Sotozono? Because as Dr. Nani mentioned, sometimes our patients came with a large tumor, and sometimes also with like this case that we decided to do systemic chemotherapy. What's your experience on that? Thank you.
We don't use systemic chemotherapy. Only one case I did systemic chemotherapy, but complication developed, pixel defect. And so, only one case I experienced. As Dr. Kitazawa presented, complete tumor resection and ocular surface reconstruction and post-surgical topical IVFU standard management at present.
Okay, thank you.
I think we've reached our end of the sessions. So thank you so much for all the presenters and panelists, Prof. Sotozono, Dr. Koji Kitazawa, Dr. Hideki Fukuoka, Dr. Neni, and Dr. Nina, and also our presenter, Dr. Fujimoto and Dr. Nabila. So maybe I will conclude these sessions with the reminders that OSSN usually happen in the older people, but we also have to watch out in the pediatric patients, especially with the comorbidities, and also the patient with the persistent hyperemic are already treated with eye drops. We also have to be cautious about the ocular tumors in those cases. So thank you for all for the participation. I close this session. Good evening. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, everyone.
Thank you, everybody. Bye-bye.
Please, Dr.
Thank you.
Shall we take picture first before we close?
Aku gelap nih.
Maybe for the participants can open the video. We can take a picture first.
Okay, Dr. Kitazawa, Fujimoto, and Fukuoka disappeared. So therefore,
Already disappeared.
one shot, please.
Maybe Dr. Nabila, please help to take the picture.
Okay, doctor.
There. Okay. 1, 2, 3. Okay, next. 1, 2, 3. Okay, next. 1, 2, 3. Thank you.
Thank you.
Okay. Thank you, Professor.
Bye.
Recording stopped.